Thank you very much, and I'd like to thank you for inviting me today. And I need to add a thanks to AstraZeneca because they've funded my trip over here, which is great. So what I'd like to do is give you a whirlwind trip through about 20 years of research that has been my hobby in trying to prevent exacerbations of asthma, or attacks or flare-ups, as we perhaps should call them now. So there, Nottingham isn't actually mentioned on the map, but it's about 2 hours north of London. You can see Manchester just above and to the left. And unlike Manchester, and unlike Newcastle and Sydney, the sky is blue every day in Nottingham, and that's the weather I left to come to this rainy part of the world. And that's the Clinical Sciences building where we work. The hospital is somewhat older. You can see I photographed it on the same day because the sky is still blue. The hospital is over 100 years old now and is in absolute need of being demolished and rebuilt. But as you're aware, the NHS has a limited budget, and I think we're going to be there for at least another 10 to 20 years or beyond my retirement. So this story really began in 1995. I was a research fellow doing my PhD with Anne Tattersfield, who some of you will remember. And my PhD was actually on a completely different subject. I was studying the adverse effects of inhaled corticosteroids. And one day I just had an idea, and it was absolutely while cycling home from work. The NHS executive at the time had put a call out to fund research in asthma to fill our gaps in knowledge, which is quite broad, but they wanted to try and increase our knowledge of asthma. And I was cycling home, and I recalled a light bulb moment when there was an extract in the 1995 BTS asthma guidelines that said that current guidelines recommend that patients should double the dose of their inhaled steroid temporarily if their asthma deteriorates or at the first sign of an upper respiratory tract infection. But there are no published trials which have specifically addressed this question, but the recommendation should be retained until we have control, although controlled studies are needed. So this, to me, fitted perfectly with the call to fill gaps in evidence. And I put in my first grant, I guess, to the NHS executive, and I was awarded £180,000 to answer the question of whether asthma attacks could be predicted and then prevented with a doubling dose of inhaled steroid. So I got going on my first randomized large controlled trial, which unfortunately had absolutely nothing to do with my PhD and didn't contribute to my PhD at all. And then we published the results in 2004. It was a single center study. And I was absolutely delighted that we published this study in the Lancet. And the results were that we randomized around about 400 patients, 200 to doubling their dose of inhaled steroid and 200 to placebo. So it's quite a complicated study. It was double blind. And we managed to take patients who were on virtually any inhaled steroid combination. And we managed to get the pharmaceutical companies to give us active and placebo inhalers of virtually all inhaled steroids. So all companies agreed to participate, which was great. And we simply added an active or placebo inhaler to the patient's treatment at the point that their asthma was deteriorating. And as you can see, in terms of peak flow and symptom scores, there was not a scrap of difference between those that doubled their inhaled steroid versus those that stayed on their same dose of inhaled steroid. And in terms of exacerbations or courses of prednisolone started, it was 11% in one and 12% in the other, with a relative risk of 0.55 to 1.64, which is a pretty big range. And I would go on to argue that
it is not impossible to get a negative underpowered study into the Lancet, as long as you write it really carefully. For those of you that remember Anne Tattersfield, her one was attention to detail. And I think it took us about a year to finalize that paper and send it off. And I'm sure if it hadn't have been written quite so carefully and in such detail, the Lancet wouldn't have accepted it. But there was other studies. There was Mark Fitzgerald's doubling dose of budesonide, which came out just before our study, which was also negative. And more recently, there's been a Cochrane review pulling together all the studies that have looked at doubling the dose and have concluded that doubling the dose of inhaled steroid does not prevent or shorten the event of an exacerbation. So if doubling dose does not work, why don't we look at a bigger dose? And I then applied to the National Asthma Campaign to look at whether a fourfold increase in inhaled steroid could prevent an exacerbation. A relatively modest amount of money to run another large study, but we continued. These were both single center studies. We published this one. There's this quadrupling the dose of inhaled corticosteroid to prevent asthma exacerbations. And I guess if the question is what's better than a negative study, you might say a positive study, but I'd actually say a borderline positive study, because it gives you the opportunity to go and do yet another study. Whereas if this one had been clearly positive, it would have been difficult to do the next study. And this was an interesting result because the primary outcome there was the number of patients requiring oral corticosteroids. And you can see that it was 18 out of 197 and 29 out of 206. And so that was not a significant difference. But when we looked at the per protocol analysis, which was just those patients that either quadrupled or didn't quadruple, but did start the intervention, so either placebo or quadrupling, you can see that we did then get a difference, 19 out of 38, so a 50% event rate in the placebo group, and 12 out of 30, 56, so about a third event rate in the active group, and a significant difference. However, that wasn't the primary outcome, and obviously there was an imbalance in the two groups, 56 and 38 in one, so it was always questionable whether this was a definitive answer. But it fitted with Farazi's study that was a 5-fold increase in inhaled steroid that seemed to be positive, and it did get incorporated into GINA guidelines, saying that if you're going to increase the inhaled steroid, you probably should do it by a 4-fold rather than a 2-fold. However, because it wasn't definitive, the HTA, the UK feeling was that a definitive study was still needed. So I put another grant in 2008 to the HTA program, which is a real life sort of funding organization within the UK. And they took a few months looking at it and said, it's not really suitable for us, rewrite it and send it to the EME program, which is an efficacy mechanism and evaluation program funded by the MRC. So I did that, I rewrote it and sent it to the EME, and they promptly rejected it. And then I found out that the HTA and EME actually sit in the same office. And all they needed to do was sort of transfer it from one side to the other and say, would you have a look at this? But of course they didn't. They asked me to rewrite it and spend several months redoing it just to have it rejected. But then in 2010, the HTA, who had originally rejected the grant, commissioned a research call to determine whether increasing the dose of inhaled steroids could prevent exacerbations. And this time I was successful, even though I was rejected above. And interestingly, they asked, I don't know if they have this in Australia, but they asked for ideas of what research should be done. And so you can put in a little summary of what you think is an important project and an important question, which I had done a year earlier, suggesting that this was an important question. And then they put in a summary of what the important question is and what they want answering. And they actually put it word for word, what I'd sent in. They hadn't even edited it. It was exactly as the proposal went in. So I put in a proposal and I won the outcome, which is quite common.
Yes. So you can see the scale of the money has gone up quite a bit from the first two grants. So this was my first step into a multi-center clinical trial. And the objective was to determine whether there was clinical and cost effectiveness of a self-management plan, which included a temporary quadrupling of the dose of inhaled corticosteroid when asthma control starts to deteriorate. And our primary outcome was unscheduled healthcare visits or need for systemic corticosteroids, defined as a 3-day course of corticosteroids. So we aimed to recruit 2,200 patients from these centres in the UK. And in fact, as we were designing the study, a few people were moving around. So the lead for East Anglia moved up to Aberdeen, and the lead for Aberdeen moved down to Southampton, and London agreed not to participate, so somebody else in Aberdeen took it on. So even in the development stages of the grant, we had principal investigators moving around. Now, and I don't know how many of you have actually run a multi-centre clinical trial. I know Peter has, because we discussed it this morning. But the first 6 months, I don't know if, Peter, you had any shots that looked a little bit like this. So the most frustrating thing was I discovered that our university probably wasn't set up with enough resources in the contracting department. And the biggest delay in this study was actually just getting the contracts between the different organizations. And I would suggest that if you don't like sort of feeling like these pictures, don't attempt a multi-center randomized trial. Would that be true, Peter, or was yours easily done? Oh, sorry, come back. So the methods were 2,200 patients randomized to 2 self-management plans, which were absolutely identical. They were the ones being used at Asthma UK at the time in the UK. And then we altered step 2, and step 2 is where you're beginning to lose control of your asthma. One group were asked to quadruple their dose of inhaled steroid for 7 to 14 days. So if they felt better and recovered at 7 days, they could return to their normal treatment. They could go on up to a maximum of 14 days on the quadrupling dose. And this was versus no change in inhaled steroid group. And both groups were encouraged to take extra bronchodilator medication at that time. As I say, the primary outcome was time to start prednisolone or need for unscheduled health care. Inclusion criteria were very broad. We wanted this to be a study that was really very valid for primary care at the time. So it was patients 16 years of older. They just had to have a clinical diagnosis of asthma. We didn't confirm that diagnosis. They were on any licensed dose of inhaled steroid in the UK. So from 100 up to 2,000 micrograms of BDP or equivalent. And they could have any other controller medication on board, so long-acting beta agonists, leukotriene antagonists, long-acting muscarinics, and at least one severe exacerbation in the previous 12 months, as we thought that was the best indicator for them having another exacerbation for our power calculation. Exclusion criteria were any anti-inflammatory reliever medication, so if they're on Symbicort Smart or Foster MART regime, because obviously that alters the dose of inhaled steroid automatically. If they're on maintenance oral prednisolone, or just any other condition that we felt made them unsuitable for the study. Otherwise, it was all comers. It was open label, randomized study. We limited the visits to baseline 6 and 12 months because we didn't really want to influence behavior, or at least as little as possible. We really just wanted to do what happens currently in primary care in the UK, which is if you're given a self-management plan, usually at an annual review, and then you're not seen again for another year. So as close to real life as possible. But we did send them a text message every month to remind them to try and follow their self-management plan if their asthma deteriorated, and to contact us at that point. So participants were asked to contact their own research team approximately 14 days after reaching zone 2 of their self-management plan. And at that time, a visit was arranged to capture the outcome, i.e. did they start prednisolone
or have an unscheduled healthcare consultation in the 14 days since that intervention. So this was the self-management plan used at the time. Zone 1 is well-controlled asthma and really change nothing but continue your treatment. Zone 3 is markedly worsening and start prednisolone and seek help. And Zone 4, serious attack, you really need to seek help and usually call 999. And then Zone 2 was where things changed. So if you needed your reliever inhaler more than usual, you had more difficulty sleeping because of your asthma, or, and this was an optional, you could have a peak flow criteria if you wanted to, and where that was put in, it was a 20% fall in baseline or best peak flow. And then the action plan was written in the white box. So both groups were asked to use their reliever inhaler to reduce their symptoms, and then one group were asked to quadruple their dose of inhaled steroid, and one group just increased their reliever medication. If people were on a combination inhaler, they didn't quadruple it. So if they were just on an inhaled steroid, they quadrupled their own inhaled steroid. If they were on a combination inhaler, we gave them the appropriate inhaled steroid to achieve a quadrupling dose. Within the randomization, we stratified by smoking status because we included ex and current smokers in the study. So it was stratified by smoking status and also inhaled corticosteroid dose, because we thought that was likely to be an important balancing factor, because we thought that this would probably work better in those on a low dose inhaled steroid quadrupling rather than a high dose and quadrupling. And we took a cut point of 1,000 micrograms. So not really low highs in the guidelines, but a useful just cut point to divide patients, 1,000 micrograms of BDP equivalents. And the power was 90% to detect a 30% reduction in severe exacerbations, assuming a severe exacerbation rate of 13% in the control limb. And as you'll see, that assumption was a mile out. So as always, recruitment got off to a slow start, and there was about a 6-month delay where only our centre was started, because we just could not get agreements and contracts in place with all the other centres. So we were the lone runners in that period. And I think about here, the HTA called us to a meeting to say, hey, what's going on? Why are you failing? What are you going to do about it? We then got the other centres on board, and you can see we were still off our original recruitment target, but doing much better than we had to start with. So we had to revise our recruitment lines, and we put in the green is our best and our orange was our worst case, and we managed to just about keep above the orange, which kept the HTA off our back just to continue. And as you can see, we managed to maintain falling below our worst case scenario where the HTA were going to call us in. And in fact, an interim, not an analysis, but a look at the exacerbation rate told us that our exacerbation rate in the control limb was way higher than expected. And we actually managed to reduce our sample size. So we finished there rather than having to recruit up to 2,200. We finished at about 1,900 with exactly the same power as we'd started with. So our recruitment was a mixture of primary care and secondary care. So secondary care in orange stayed pretty steady through the whole study. And then we used the clinical research network in the UK to recruit general practice. And our change in plan when the HTA called us in was that our original 9 centres with their surrounding general practices became 279 centres. And in fact, because they were individual GP practices recruiting for us. So our study design or recruitment plan changed dramatically, but did allow us to complete the study with only a year's extension. And majority of that year's extension, 6 to 9 months, was the original delay in actually getting the study going. So yeah, we randomized 1,922 patients.
then the great majority managed to contribute to the primary analysis because it was a time to event. 81% of patients were from primary care, which was what we were aiming for originally. We hoped to get about 80-20 primary care and secondary care. Average age was 57, 68% were female, 78% were on less than 1,000 micrograms of BDP equivalents, and 70% were on a long-acting beta agonist in addition to their inhaled steroid. So this was the primary outcome. We saw approximately 20% reduction in severe exacerbations in those who quadrupled versus those that stayed on a placebo group. And interestingly, there was absolutely no difference in the hazard ratio if we adjusted for baseline features, and in particular, inhaled corticosteroid dose. So this finding was robust across the low and the high dose group, which I wasn't really expecting. I thought it would probably be more effective in the low dose group. Secondary outcomes included area under peak flow curve, where that was measured on those 14 days, and a mini asthma quality of life questionnaire. I think the data is less robust because I think the real life nature of the study meant we only actually got secondary outcome data in about 50% of the people, but where we did get it, it was in keeping with these results. Small, significant benefit in terms of quadrupling the dose compared with placebo. And then exactly the same issue at the New England Journal, where we published the results. There was a pediatric study. This was quite a different study design to us. This was a tightly controlled, randomized, placebo-controlled study, and it was truly negative. So we had a pediatric study looking at a 5-fold increase in inhaled steroid, and our study in the same issue at the New England Journal claiming to be a positive study with a 20% fall in severe exacerbations. And so obviously a lot of discussion has been, what's the difference? Is it children versus adults, or is it the two different study designs? And an interesting editorial compared the two studies. So the children's study was a lot smaller. It was 254 children with at least one exacerbation in the last year. They were on much lower dose treatment, so they were on FP88 micrograms twice a day, and they added 440 micrograms for 7 days in the yellow zone. And I think the yellow zone was probably not dissimilar for ours. It was an increase in albuterol usage, either over 6 hours or 24 hours, or awakening, I think, once or twice. Once at night. That's right, once at night. You then hit your yellow zone, and then you had a 5-fold increase in your inhaled steroid. But one big difference from our study was the primary outcome for us was unscheduled healthcare, so going to see your GP or other healthcare provider, or a physician-assessed need for systemic steroids. And their study, I know, was actually just another jump up in albuterol need. And to me, it didn't seem that much bigger than activating the yellow zone. So I think it went from 4 puffs in 6 hours to do the yellow zone, up to 6 puffs to start prednisolone, or awakening 2 consecutive nights. And there was a similar increase albuterol use over a 24-hour period. And so if I'm trying to think of other differences between these two studies, I do question whether it's in the pediatric study, there was no requirement for a physician to think that corticosteroid was required. And I just wonder how much the corticosteroid was really required. And if it wasn't a true inflammatory exacerbation of asthma and prednisolone was started, then an intervention is not going to prevent it because it wasn't needed in the first place. But that's me being hypercritical because the study was opposite to ours, I guess. So why the difference? So ours was obviously an open label study, so it's open to bias, it's open to placebo effect. Personally, I think for something like this, an effectiveness study is more valid perhaps than an efficacy study, because in real life, that's what happens. We don't, once we've proven a drug works, we don't take out the placebo effect, or in a management plan, we don't take out the placebo effect when we recommend it for our patients. Our recommendation comes with a placebo effect, and so I feel it should be assessed within part of the study. And we also saw a difference in hospital admissions from 18 in the control group to only 3 in the quadrupling group. And I sort of feel that if it was all a placebo effect, I wonder whether we've seen such a big difference in a relatively hard outcome of admission to hospital. Other factors are that our study was, loads and loads of data would suggest that only 30 to 50% of people are taking their inhaled steroid regularly in the community. And I think there's a very high chance that our study was positive, because not only are people quadrupling, but a big chunk of people are actually starting a high dose of inhaled steroid compared with nothing, being on nothing or a low dose of inhaled steroid. And we had a very high exacerbation rate. So we powered it to have a 13% exacerbation rate in the control arm, and we actually got a 52% exacerbation rate in the control arm, which just shows you the burden of poorly controlled asthma, I think, in the community, where if you take a group of patients who are really just normal patients in the community, yes, they've had one exacerbation in the last 12 months, but half of them had another course of corticosteroids in the next year. So if you compare that with the children's study, it was double blind, it was placebo controlled, and the editorial said therefore it's perfect and can't be faulted, whereas ours was questionable. But actually, it was very unreal life, if you like. It was more unreal life than some studies. So you had to be more than 75% adherent during the study, prior to the study, to get into it with your inhaled steroid. And of those people that completed their diary cards, compliance with the inhaled steroid maintenance treatment was 98%, which is very, very far from real life, certainly in the UK. Maybe it's different in America, but I'd be surprised. And as I've already discussed, was there actually a signal to be prevented? And if you look at a graph in their study at the mean, and yes, it was the mean, so there will be more, but the mean albuterol puffs at the peak of the exacerbation were 3 to 4 a day. So you've got an exacerbation that is requiring only 1 or 2 episodes of beta agonist use when you consider it's 2 puffs per activation. So that's my personal thoughts, that it wasn't just a real life versus a placebo-controlled study. I think there was some weaknesses and problems in our study, but I think there were also some weaknesses and problems with the pediatric study, which I don't think were truly brought out in the editorial. And I think the overall message from the editorial was that more inhaled steroid doesn't work. So they very much they said that our study was a small effect and the children's study was negative. So overall, it's something that probably shouldn't be recommended. But obviously, just to build on that point, ours was a real world pragmatic study. I've become a fan of as close to pragmatic studies for these kinds of questions as possible. But I still feel that randomization is important. I think it's almost impossible to adjust for non-randomization, because there's only so many things you can measure and adjust for. But our study really asked, can it work? Does it reduce exacerbations in real life? Yes, it's got low internal validity, but high in external validity. Whereas the children's study was double blind and therefore highly controlled. And I guess it's asking the question, does it work under ideal conditions, which are not real life, and therefore has high internal validity, but low external validity? And I'd be interested to know what your thoughts are. Let's just forget the other details in the design. But if the 2 studies were identical in terms of criteria when to start treatment, and one was positive and one was negative, which would you go by? Would you recommend it because it was positive in a real life study, or would you not recommend it because it was negative in a placebo-controlled but artificial randomized controlled trial, which would make a great discussion? So in summary, Don't be put off if you have negative or inconclusive studies. It gives you a great chance to apply for funding and move on to another study. Multi-center studies are hard work, even harder work than I guessed it would be. And a good clinical trials unit with an excellent trial manager are absolutely essential. If you do set up a study, allow even more time for approvals. I have no idea what they're like here, but I saw a few nods of the head to suggest you have similar problems. And I would suggest that the first 9 to 12 months of a study is just to set it up and get the contracts in place, and then start your recruitment numbers about a year later. And if your original plan doesn't work, just think differently. We opened 279 general practices, which was not in the original plan, and why our trial manager nearly had a breakdown. Thanks for inviting me.
Thanks, Tim. What a study. Before we take questions, I might ask, because I'm sure there'll be debate about real-life studies versus randomized controlled trials. But now, have you changed the way you write your action plans as a result of the study?
So I'm going to confess that I don't actually write action plans.
I thought that would be the answer.
So I actually verbally communicate them.
Yeah.
And double check that information has been taken in rather than just write it down. Because I'm not sure. Maybe the best would be to do both. But yes, so if people are on a low to moderate dose of inhaled steroid, and they want a step to try and prevent the need for systemic steroids, which most do, then I suggest they quadruple the dose. If they're on a high dose, then I'm more cautious, because we pushed up the dose to 6,000 to 8,000 micrograms of inhaled steroid, and I think the data for the systemic effects of that high dose of inhaled steroids are not great. But if you believe the sort of Too Good study, that you probably are, if it's a linear relationship and Too Good was right, it would suggest you're getting the same systemic effects as you might do from a course of prednisolone. So at the high dose, you're probably just as good starting with prednisolone, because the systemic effects may not be that much greater. But certainly up to 1,000 micrograms, yes, we now suggest that people quadruple.
Okay, Max.
Thanks for a very nice talk. I really enjoyed that trial too, because I guess it's a very important question. I think, would you maybe be able to elaborate on, obviously it looks like the effect is not quite as big as we would have liked to see. Could that be because it might just be an effect in a small subpopulation that we need to identify, or also possibly looking at exacerbations as one umbrella term? Are we having an effect on a specific type of exacerbation that we maybe should look at?
Yes. So we in a sort of initial piece of work to find out what we thought the important difference was, most people said 30%. So 30% reduction would seem a reasonable difference to go through the palaver of explaining the self-management plan, getting people to follow it, and actually add in another inhaled steroid. However, if you think about the background exacerbation rate, so we powered it on a 30% reduction on a 13% background rate, and we actually got a 20% reduction on a 50% background rate. The actual number of exacerbations prevented was bigger than we set out. So it was probably still smaller than I would have liked to make this a sort of we must do this type approach. But equally, we were testing it in probably the worst scenario possible. So there would have definitely been anything up to 30 to 40% of those patients, if we believe other studies, that didn't even have asthma. We've got the poor adherence, and how many people actually did quadruple their dose. Those that reported that they did it brilliantly.
just like they would with their with standard adherence. So I guess we were testing something in what I consider to be the toughest conditions, and we still got a 20% reduction. Whereas I'm sure if we were less real life and more people did it and did it exactly as they were meant to, I suspect the effect would have been bigger. But it is what it is. As we have no alternative but to wait for the course of prednisolone to start, then I think I would suggest we go with it. Have we got different types of exacerbations? Almost certainly. You know, there's the question of, do viral exacerbations respond to more inhaled steroids? I think probably they do. If we look at the AZ data on SMART, that seems to work whether it's viral or not. And I think that's more evidence that a higher dose of inhaled steroid does work. So I think there's enough evidence. I don't think our study's there in isolation. I think there's enough other studies using different ways of increasing the dose of inhaled steroid that suggests it does work. And it's something we should keep in and not throw out, as I think the pediatricians certainly are suggesting that they wouldn't now do it in kids. And I think I'm not sure if I had a child who was getting worse, I think I would still try a higher dose.
Peter?
Yeah, that's great, Tim. Just so two sort of unrelated questions. Is there any downside in the placebo group or in the control group? Is there any adverse effect of not increasing the house that came out of your trial in the video? Can you just repeat?
Yeah.
So the question is, are there any negative effects in the placebo group in either of the trials from not increasing inhaled corticosteroids?
I don't think so. There were certainly adverse effects in the quadrupling group. We got a fairly high incidence of thrush and dysphonia from the high dose inhaled steroids, and we were quite careful not to describe the placebo group as placebo but as standard care, because the guidelines at that time just suggested that was the standard of care. And I've seen a couple of comments on, why did you not compare it with doubling the dose, because that's standard of care, but clearly it isn't now. So we compared it with placebo. What were you getting at in terms of down?
Well, your comment about if my child was sick,
Yeah,
I would want to do something. And the question is there a downside of not doing it? And apart from, it sounds like it's just oral steroid use is the main issue.
Yeah,
one way or the
yeah. So reducing the need for oral steroids and hospital. You know, we saw a big difference in hospitalisation for severe attack, 18 to 3.
So that's pretty important.
I think that's quite a big difference.
So my other question is just trying to think how you would reconcile the two studies. And I wonder, is it possible that the dose of inhaled steroid at exacerbation is irrelevant, so as supported by the pediatric study, but having some inhaled steroid when asthma deteriorates is what's needed?
And that's what I was getting at with the adherence, is that I suspect some of our adults in the standard group were on no inhaled steroid, and we put in a high dose that was therefore a high dose versus nothing, rather than a high dose versus a low dose. In the pediatric study, everybody seemed to be taking their low dose, so theirs was truly a high dose versus a low dose. So that could be a difference.
So does your study support PRN steroid use?
So the question was, does our study support PRN use of inhaled steroids in asthma? I don't think it supports it. I guess it probably does, because it's supporting an increase in inhaled steroids at a worsening time. Yeah.
Is that your next grant? Steve.
So two questions there. One is about guidelines. They're commenting that quadrupling ICS doses in the Australian Handbook guidelines for adults, but not in the UK BTS guidelines now. I guess kind of a carry on of that is what's the place of the guidelines now that you have kind of the equivocal data here, I guess, between the two studies of where do you go from here with guidelines?
Yeah, so I thought so GINA certainly suggests it, but lack of clear-cut evidence. We're in a slightly confusing position in the UK now that we have two sets of guidelines, BTS ones and NICE now. I don't actually know what the NICE ones recommend, but I thought there was a hint at if you're going to do anything quadruple, certainly not double. But I would very much hope that the guidelines would now suggest including a quadrupling dose when they're next revised.
And was there data in your trial about chest infections with the exacerbations?
So we looked for evidence of pneumonia for a month after activation and found no evidence of an increase of pneumonia or chest infections in the quadrupling group. One patient died in the quadrupling group of a severe pneumonia, but as far as we could tell, although they were in that group, they hadn't actually done the intervention prior to admission with the pneumonia to die. But that was only on what we could extract from the medical records. So can I ask for a vote? Because if we
He
did,
likes to win.
no, because it was on our study. If we did our study and we made it double blind and it was negative versus our study, which was open label, but much more real life, and it was positive, what I'm interested is which study would you take the evidence for? Would you take it from the tightly controlled double-blind study in adults, or would you take it from the real-life study in adults? So not taking the children's study into account, because they differ in more than one way. I was just wondering whether because there's clearly a shift from placebo-controlled, randomized controlled trials to more pragmatic studies. I just wondered where people are now, whether they just believe that it's all placebo, or whether the reflection of real life placebo should be incorporated into what we do. So hands up if you would follow the evidence for a randomized controlled trial where placebo effect is taken out, I guess, is the question.
So is the question, you mean,
which would you,
what would we do in practice?
Yes.
The question is, what
would you do in practice? Would you follow
those two results?
Yeah, so our study exactly as it was, but double blind. In other words, taking placebo out, or do you believe placebo should be in and negative? Yeah,
or the trial
as it was positive.
Yeah.
So in guidelines, and what would you do? Would you follow a real life study with placebo effect included, or a randomized controlled trial with placebo effect excluded? So hands up for the
positive versus negative.
Yeah. Hands up for you to follow the real life study with placebo effect as part of the outcome.
And as you reported.
Yeah. And hands up if you'd rather have the randomized controlled trial with placebo effect excluded.
Chris, did you put your hand up twice?
So it absolutely depends what question you're asking.
Okay.
And if you're asking, what should we tell your study population in a general practice clinic to do to improve their asthma control?
Yeah.
Then you go with your study.
Yeah.
If you're going, do inhaled steroids make a difference to exacerbation frequency per se? Is it a biological question?
Yeah.
Then you go with the placebo control.
That's
so they're answering different questions.
Yeah.
They're not better or worse.
No.
They're just attacking different elements of the problem.
I agree entirely. But yeah, the question was, what would you do in your clinical practice?
Yeah, so the clinical practice, it would be nice to have both.
Yeah.
Well, no, because then if you've got a completely apparent patient, who is definitely taking their inhaled steroids, there's no point in a pumping. If you've got a patient who's got a debate about whether they are or they are not,
okay,
then it's worth telling them because the message may get through with their crook to take more steroids. So it means you've then got, you know what's actually going on and you can direct it to the individual patient sitting in front of you.
So would I be right in saying that you think the study was primarily positive because of poor adherence with inhaled steroids as a background, which I do.
I think that's a really good explanation of what you've got.
I agree.
But whether that's true or not is different.
Sure.
Peter Walker, you also voted twice. Would you like to make a comment?
I think you voted twice for the randomized controlled placebos.
I essentially agree. Although I mean, I'm not sure if it's all just based on non-adherence. You may still be getting an effect there. I'm not sure you can rule that out necessarily either under those circumstances.
Sure.
But I suspect when you've got higher doses and better adherence, it makes sense that the effect of doing this becomes less. Yeah. So if you're already on very high doses of corticosteroids and you're going to quadruple it to enormous doses of inhaled steroids, the mind boggles to tell the person it's very hard for you to swallow that stuff.
Even though prednisolone does.
Would you?
I guess the is going to work and prevent you going on to using prednisolone. I'm not sure prednisolone always works. Either, but are you any better off anyway? And perhaps you're worse off with all these local effects, and you may just get on with it, and you might be better off just saying
sure. Yeah.
Would you have liked to have had an eosinophil count to see who improved and who reduced exacerbations and who didn't?
I think the question is, when would you have done it?
Yeah.
So would you do it at baseline, or would you do it at the worsening of the asthma? And I'm not sure we know the answer to that, but quite clearly putting it in at the beginning of worsening would be very difficult. If we do it at baseline, I'm not sure that a baseline eosinophil count would predict what's going to happen at exacerbation. So
that's the sort of thing that would be perfect for the Salisbury Common Cold unit, where you get a group of a dozen people and you keep them there for their entire summer, and you just keep doing horrible things to them, like give them a common cold, and you just measure and measure and measure. And unfortunately, with cheap airfares, I just can't recruit anybody to the Salisbury Common Cold unit for a holiday anymore.
No.
You could sample a small group of people often enough, you might get an answer to that. You wouldn't need 2,000.
No. So what we would have, I mean, obviously what we'd have loved to have done is looked at the patients as they were exacerbating in much more detail, try and learn what was happening in exacerbation, but it would have just, one, it would have made it ridiculously expensive, and secondly, it would have changed the nature of the study because we wanted as close to real life as possible. Okay.
Okay, Steve.
One more question. With your trial, did you have any qualitative results about patient experience with your intervention?
No, unfortunately not. But we have got, it's not published yet, but we've got an economic analysis which shows it's a cost-effective intervention.
Imagine 2,000 qualitative interviews.
You would have needed a few hundred patients if you had
the right outcome.
The right outcome measure as you find
All right, well, I might draw this to a close. Thank you very much, Tim, and thanks again to Janelle. I think it's been a fantastic couple of hours, and I would also like to express gratitude to AstraZeneca for their sponsorship, and also to the CRE for the sponsorship of Janelle, and thank you all for coming. And thank you to those online.